Today we will continue our series of the things I learned in residency. There are a few common presentations that you always tend to encounter. For example, when suspected stroke, this is very common. GI bleed, this is a common one. Chest pain with elevated troponin, suspecting STEMI, so this is chest pain with elevated troponin. These are common things that patients get admitted for. Another thing, UTI. Another thing, heart failure. One more thing, COPD exacerbation. Pneumonia, it's extremely common, pneumonia. Obesity hypoventilation syndrome, this is very common, but it's underdiagnosed. So this is kind of the common things that usually happen. And then sepsis, this is also a very important thing, sepsis. So every patient usually have some sort of past medical history background that it is stable. Past medical history could be anything, could be common ones that I see is hypertension, heart failure, AFib, and hyperlipidemia, diabetic. This is very common. Also, another common presentation, DKA with the diabetic, I remember it. So this is kind of the common things that we need to master. So for stroke, usually, so this is usually have some baseline. Every patient has some baseline background of medical issues, but something pops up that make them need to be hospitalized. And these are the examples of things that make them need to be hospitalized. So for stroke, for example, what the usual common orders that we do is that we do CT head, that's from the ER, brain MRI, and the other thing that we can do, they do lipid panel, and we also do hemoglobin A1C, and this is kind of the common test. Echo with bubble study, carotid Doppler, and neuro consult. And sometimes if patient have headache and you suspect some giant cell arthritis, you can do ESR, wouldn't hurt, just to rule out temporal arthritis. You can do urine drug screen, just kind of to rule out if there's any toxicology that causing their symptoms. And of course, detailed history, detailed exam. And the common medications that they are on, if they're not on aspirin, then they need to be on aspirin 81 milligram, Lipitor, 40 milligram. So these kind of the common things that in stroke, and usually depend on their symptoms. They do, and then we do PT, OT, speech therapy, and PT, OT to evaluate if they are able to go home or if they need some sort of rehab. Most people, they may need rehab to get them stronger. So that's our goal. For stroke is to prevent the next stroke. So that's kind of summary. I don't want to go into deep details. We're gonna make different series to go into more details, but this kind of, I want to make this as summarized as possible. Now this is for GI bleed. It's gonna be interesting as well. So for someone that comes in with GI bleed, usually try to find out what caused the GI bleed. Are they taking ibuprofen? Are they taking aspirin? Anything like that. So what you would do, you hold the aspirin if they're on aspirin, or NSAIDs, okay? And you're gonna monitor CBC and transfuse to keep hemoglobin above 7, and of course Protonix 40 BID. And you can give them sucralfate 1 gram PO TID, and you continue normal saline hydration 100 ml an hour, and then you consult GI to plan for EGD. Actually, this is very important because usually most common cause of GI bleed, even if it's lower, it's upper GI bleed. So that's why we do EGD. 90% of GI bleed is caused by upper GI bleed. So that's what we usually do. That's the common orders. And then you can add PRN medications like Zofran, monitor vital signs, and then even on Epic there is something that's called nursing orders, just to have to maintain hemoglobin, which is maintain hemoglobin above 7, transfuse 1 unit if hemoglobin drops below 7. So this is kind of give the nurse the idea that if the hemoglobin drops, they can just go and transfuse. You can do type and screen as well. So this is kind of the presentation of GI bleed, and usually once they do the EGD, trying to find out what could be causing that, and on discharge you hold these medication that could have caused it and you discharge them with the protonics, obviously. So this is for GI bleed. Now we will talk about chest pain with elevated troponin. It's kind of interesting as well. So these kind of patients, sometimes there's a TEMI score, but sometimes on the ER they don't follow that because they're scared this something is a between life and death situation, so they tend to be more conservative and they admit anybody that they suspect elevated troponin with chest pain. So the way we usually handle that, we do cardiac enzyme trending, we trend it, okay, and then we do EKG. If there is ST elevation, that's the most important thing. I'm just trying to kind of make it as summarized as possible. ST elevation, is there ST elevation or not? If there's ST, that's STEMI, that's an acute, you have to call the cardiology right now. They have to open the blockage. If most of the time there's no clear ST elevation, so most of the time it's NSTEMI. If it was a STEMI, it's probably going to be admitted to cardiology service. So most of the time they have NSTEMI and they have some other problems, that's why they admit them to the medical service. So NSTEMI, so the way you do it, just do the cardiac enzymes and regular labs, CBC, BNP, obviously on everybody, and you consult cardiology and kind of talk with cardiology if they want to do some heart cath, just kind of to see if there's any blockage that they can fix. And the common medications that I see in this setting usually, also aspirin 81, Plavix, sometimes they add that 75, Lipitor 40 milligram, you know. So you check lipid panel, A1C, just kind of to be perfect, and echo as well, because if there is HFrEF, then you can do the guideline directed medical therapy for the heart failure reduced ejection fraction, which include lisinopril. You may see that, may see metoprolol, common. We're going to talk about that as well. Spironolactone, Entresto if it's HFrEF. If there's volume overload, you may add Lasix. We'll talk about it in heart failure topic. So the other note on these patients as well, if they are dehydrated or they have some sort of renal disease, renal failure, they are usually have some sort of elevated troponin. So the way you can say that, okay, there's elevated troponin, and especially if they don't have chest pain, and with the T-wave abnormality in EKG without any chest pain and no discomfort, and and then you can say painless acute coronary syndrome cannot be ruled out, cardiology consulted, and will continue diabetic diet or heart healthy diet, and advise them to quit smoking or and exercise, all these educations about acute coronary syndrome, admit them to telemetry, and have them follow up with cardiology and discharge, of course. Okay, so this, I like to have the video short, so this is kind of I'm going to talk about these three, then I'll make another video to talk about the other ones. So this is kind of the idea. The stroke, you do CT head, MRI, echo, carotid Doppler, aspirin, neurology on board. GI, hold aspirin, NSAID, Protonics, GI, EGD. Chest pain, you do the cardiology consult, EKG, trend troponin, and see how that happens. And that's kind of summary of the first one. And then next lecture, we're going to talk about then other common ones.